Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Byrd, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Together, we will rewrite the narrative around this remarkable stage from being something to dread into a beautiful transition. Well, I just got off of the recording with Dr. Jayne Morgan, who you are going to be hearing from today, and I had to jump on the microphone to do her introduction. I feel, after talking with her, I feel so empowered to fight for women's health and research. I learned so much about cardiovascular health in women in midlife, and it was just such a pleasure to talk to her. I wanted to catch my emotion of how excited I am after finishing our interview that I wanted to introduce her right now. Dr. Jayne Morgan is a cardiologist. She's an on-air medical expert. She is the creator of the Stairwell Chronicles. So if you follow her on social media, you will find her Stairwell Chronicles, where she gives medical advice. She gives health and wellness education. She is an advocate and a fierce fighter for health equity. She wants more clinical trials for women's health and so much more. So I'm just delighted to have her. It was such a pleasure when she agreed to come on. I was like, how do I make this happen? This is so awesome. So I'm very delighted to have this episode on the podcast in the library forever. And so here we go. My interview with Dr. Jayne Morgan. So first of all, thank you, Dr. Morgan, so much for being on the podcast with me. I have been, like I said before we started recording, I watch your career and I'm so in awe of what you do and the service you're providing for all sorts of healthcare, but especially for women. And so thank you for coming on today. I would really like this episode to be informative and educational for women as we talk about cardiovascular disease.
I love it. Thank you, Victoria. It is always a pleasure. So we're looking forward to it. Let's kick off 2025.
Yeah, and let's take care of ourselves. I think, one of the things I talk to a lot of women about is advocacy for their own health. And part of being an advocate is understanding the why behind things that are happening to us and what we can do for prevention and for treatment. So I'm really excited to dig in with you today.
Great.
So the first thing I wanted to talk about are the hormonal changes that happen in women in midlife and how that affects the heart. So what are some hormonal changes during perimenopause and menopause that affect heart health?
So when we look at what's happening during perimenopause and menopause, and we have to remember that perimenopause can start as early as 35 years of age. So, this is a tricky time because you could be in perimenopause, meaning your hormonal levels like your estrogen, your progesterone, your testosterone are starting to decrease, but you're still fertile. You're still ovulating. You're having regular menstrual cycles. So even though you're beginning perimenopause, you also are able to get pregnant during this time as well. So it's that fun time, right?
Yeah.
In a woman's life. And so when you're having perimenopause, when you're starting perimenopause, those estrogen levels in particular are decreasing. That's giving you a lot of the symptoms. That progesterone is starting to decrease, which may be giving you those symptoms of sleeplessness or insomnia. Testosterone levels are starting to drop as well. And that's why we talk a lot, maybe we'll get to it today, about exercise and weight resistance to keep up your muscle mass and bone mass. But with regard to the heart, estrogen is one of the key factors, because we have estrogen receptors, not just on our uterus, and on our ovaries, but also on our heart. We have direct receptors on those on the heart, and the estrogen works by directly binding to those receptors for a direct effect, a protective effect on the heart. But also estrogen is an anti-inflammatory agent. And chronic inflammation, you've probably heard about it from processed foods and obesity. Chronic inflammation, inflammatory processes in the body, increase the rate at which you develop atherosclerosis, that big word that just means plaques and blockages in the arteries of your heart that can cause a heart attack. And so estrogen then is very important because as those estrogen levels drop, you lose that protection. You lose that anti-inflammatory protection. You can have an acceleration of developing that atherosclerosis, those plaques. And estrogen receptors are also on your arteries. And so as those levels drop, your arteries can become stiffer. And you say, so what? What does that mean? Well, one of the reasons we can maintain normal blood pressure is that our arteries are elastic or pliable, or what we call compliant, meaning they have capacity. They can expand and contract like a rubber band, expand and contract when they need to. That's what controls our blood pressure. As our estrogen levels drop and those blood vessels stiffen, they no longer have the ability, or they have less of an ability to kind of expand and widen. And so your blood pressure can go up because they're in stiffer tubes. And blood pressure is what? A risk factor for heart disease. And now we've got another risk factor for heart disease. And we can talk about more of those, including how estrogen interacts with cholesterol pathways in the liver. And you can see even your cholesterol levels start to rise. That sleeplessness oftentimes is due to progesterone levels dropping as well. And so this is a time when we really have an increased risk of heart disease because sleeplessness, even though it's more related to progesterone than estrogen, is also a risk factor for heart disease. So here we are now in perimenopause and menopause, and we've got all of these independent risk factors for heart disease that can all start happening at once. And that's one of the reasons why prior to menopause, a woman's risk of heart disease is half that of a man's. And then as she goes through menopause and gets on the other side, it actually equals that of a man. And by the time we reach 70, we actually surpass that of a man. So here is one area where we are really not trying to be equal to men, right? Yeah. We want to be inferior. We like our inferior status because we have less heart disease because we've got that estrogen protecting us.
Yes, exactly. And I think that is definitely, that's a game I want to lose with men.
Right. We lose to win.
Exactly. Mm-hmm. So so if we talk about the decrease of estrogen in menopause and the fluctuations in perimenopause, a lot of women seek hormone therapy as an option to replace that estrogen and progesterone that they're losing. Are there specific cardiovascular benefits and risks associated with menopausal hormone therapy?
And I think when people think about hormone replacement therapy, and it can also be called menopausal hormone therapy, so HRT or MHT, depending on what you're reading. And that really is a broad term. It can be estrogen, it can be progesterone, it can be testosterone, it can be any combination of those. But when we're talking about heart disease, we primarily are really talking about that protection of estrogen that we lose. And as we lose it, we get these risk factors for heart disease start to increase. And we see the outcome of that because actually our heart disease risk doubles during that time. And then we add on top of that our symptoms might be different, which we can talk about a little bit later. And that leads us to delay seeking care or receiving care at a medical facility. And it's one of the reasons why the first heart attack of a woman is more often fatal than the first heart attack of a man. So when you're looking at hormone replacement therapy for the heart, we'll just talk about the heart. There may be any number of reasons that you may be looking for it. And sometimes you may be seeking hormone replacement therapy just to feel better. You've got so many symptoms. It's not just hot flushes and night sweats, but there are heart symptoms. You can have palpitations that can be really, really scary. And we'll send you off to a cardiologist, which is an okay place to be. Get your workup. Make certain you don't have any cardiac issue going on. Heart disease remains the number one killer of women. So I'm not saying ignore your palpitations. However, palpitations during perimenopause can be quite common. And those are the types of symptoms that can be controlled with estrogen. There's nothing wrong with feeling better. And if you can get relief from these night sweats, if you can get relief from the sleeplessness and all of the other symptoms. So there are 84 symptoms of perimenopause, including if you are noticing that you're starting to switch deodorants and change deodorants, or you have a drawer full of unused deodorants, you keep changing, you might be in perimenopause, because as your hormone levels change, we actually have more of a difficulty in controlling underarm odor. And if you are having those symptoms, that might be a symptom that you're in perimenopause. There's a symptom that nobody talks with you about. In addition to palpitations, what about vertigo? You can start to feel vertigo, that dizziness, or inner ear ringing as well. Tinnitus, we call that. So there are a number of symptoms that we don't really talk about. When I say we don't really talk about, I mean the medical establishment, because we don't really learn them. We're not really trained on them. Menopause is not something that is taught to physicians and medical students. So when I say we don't really talk about them, it's because we're really talking about them. We're not taught them. So you can go to see your physician. Your physician literally could not know what you're talking about. You may be armed with more information than he or she has. And we're really trying to correct that and get it into the curriculum of the medical student. Because what happens when you get to the other side, you've been practicing for a while, it's hard to unlearn something and then relearn it in a completely different way. So we need to get these students when they're young so that they can understand what menopause is. I mean, in my training, I don't think I had any training at all in menopause. Obviously, I became a cardiologist, but I had to do rotations in OBGYN, and I don't remember anybody talking about menopause. I don't remember reading anything in a book. And I certainly, even as I was going through perimenopause and I was having palpitations and I had vertigo and I was carrying, I started to take blouses to work, to the hospital, because I would need to wash up in the middle of the day and change my blouse. And I just thought, man, you know, what's happening? Is it the atmosphere? Is it the allergy? You know, what is it? All of these things were happening. And I'm a doctor. And I had no idea. The vertigo, I saw a neurologist, got a big neurology workup. They could find nothing. Palpitations, I went to a cardiologist, had a big cardiology workup. They were really, if you get palpitations, it's going to worry you. But here's the thing. This is one thing we do learn in our training. If a patient comes to you with a multitude of seemingly unrelated symptoms, like me, my deodorants don't work anymore. I have vertigo. I've got palpitations. I'm having difficulty sleeping. Instead of going to a sleep doctor, a neurologist, a cardiologist, all these places that I went, the doctor's supposed to say, this is probably not 9 different things. It's probably one thing that is a syndrome that involves all of these things. But that's not the type of thinking that takes place. And even just looking at a woman coming in a certain age range, that should be an aha moment to say, do I need to think about menopause? And that's what we're trying to make certain that people are armed with and they understand. It doesn't mean that you have to take hormone replacement therapy. That's not what I'm saying. What I'm saying is it means that you need to understand what's going on with your body, that you don't need to go to 12 different specialists. You need to have a talk about menopause. You deserve to have that conversation with your physician or with the menopause specialist, and then determine if there are options that are best for you, or, you know, whatever your circumstance, whatever your lifestyle, whatever your values are, you deserve to have that conversation such that you can make the most informed and best decision for you. Your decision may not be the right decision for someone else, but it's the right decision for you. And those conversations are not being had.
Oh, yeah. My husband's an orthopedic hand surgeon. And so he's learning about menopause by living with me in the house. And
Right.
he didn't have that conversation.
Menopause, I don't remember learning about that. I don't remember that.
Absolutely. And
The reason he doesn't remember it is because nothing's wrong with his memory. It wasn't there. He is correct.
I know. And when I was in pharmacy school, it would just be whenever we were in therapeutics, we would go through a patient's med list and they might be on Prempro, or they might be, and it would say 3 years since last menstrual period, but it was never a topic of conversation. It was never a disease state we learned about. So I think even pharmacists these days need better education, because when you finally find
Everybody needs better education on it. And here is part of the roadblock is that, when we look at evidence-based medicine, which, can take 20 to 25 years to develop, certainly 15 years. Big trials, you have to follow people for long periods of time. Because women have been excluded from research, because research on women has almost been entirely relegated to reproduction, we've been reduced to just reproduction. We have, we don't have eyes, we don't have a liver, we don't have brain. We're just breast, uterus, vagina, that's it. And that's the only research that comes our way. So because of that, we don't have these long, evidence-based, randomized clinical trial looking specifically at estrogen and heart disease. But what we do have is a lot of data on how it works and what its impact is. And and of the school of thought, especially when we're talking about women's health, that evidence-based medicine has less and less of a place, especially as we move towards artificial intelligence. We can accelerate trials. We can make assumptions. We can artificially create control groups and then accelerate the results such that we get those results. And then we really do have that solid evidence-based medicine, but it's not evidence-based. It's more artificial intelligence, is more AI-based. And that's really one of the things I'm moving towards as well. And they say, oh, we don't have evidence-based medicine for women. Well, are we supposed to wait another quarter of a century, another generation? So are we supposed to continue to be penalized because of the mistreatment? So we were mistreated in the past. Now we've got to pay it forward another 25 years. And so I think that is ridiculous. And that is why it's important to have this conversation with your physician such that you understand the risk, not the risk. And, and one of the things that, people often ask about are blood clots. And when we look at blood clots and when we look at previous trials, when women developed blood clots, it was mostly with those oral formulations, which we really don't give much anymore. Now we have sort of the skin and the transdermal formulations and local applications, and we don't see that. And so it's, and it's almost the same as birth control pills, but at a much, much lower dose. And we hand out birth control pills like candy.
Yes.
These are birth control pills that have much lower dose of hormones. So again, I'm not saying yes or no. I'm saying that there's information available. There are treatment options available, including hormone replacement therapy, and you deserve to have these conversations with your physician about what's best for you.
Are you standing in front of your mirror, barely recognizing the woman looking back at you? Perhaps you're lying awake at 3 a.m., body betraying you with another hot flash or night sweat, wondering if this is just how life has to be now. As a pharmacist and women's health coach, I've walked this path, both personally and alongside hundreds of women just like you. That's why I've created 2 powerful ways to reclaim your midlife journey: the Women Mastering Midlife community and personalized one-on-one coaching. In our community, you'll find your tribe, women who understand exactly what you're experiencing. Together, we'll navigate perimenopause and menopause with evidence-based strategies, twice monthly group coaching sessions, and a judgment-free space to share your story. But if you're craving deeper, personalized support, my one-on-one coaching program offers dedicated guidance tailored specifically to your body, your symptoms, and your life circumstances. No more Googling at midnight, no more trial and error with miracle solutions that leave you frustrated and depleted. Are you ready to transform your midlife experience? Book a free discovery call with me today. You will find the link to schedule in the show notes or check out www.womenmasteringmidlifecoaching.com for more information. In just 15 minutes, we'll explore whether community membership or one-on-one coaching aligns best with your needs, because you deserve to do more than just survive this transition. You deserve to thrive. Join us in aging boldly, beautifully, and on our own terms.
We should have choices and not just be told you have no choice. You must suffer. You must continue along this line. There's nothing wrong with just take extra blouses to work. Even if you don't have a problem with odor, you're just sweating and your clothes are wet and you need to change clothes in the middle of the day. All of this is just nonsense. We don't get supported at work. We're always trying to manage. We're always trying to finagle. We're told to suffer through it. This is just natural. This is just normal. But you know what? as you get older and your vision decreases, no one says, look, just go blind. It's just natural. Be blind, be deaf. But all of a sudden now when we talk about menopause, it's different. That's because it's specific to women, and women are relegated to a lesser category and othering. The eyes, the ears, these things are important, but something that just happens to women and not really that important. We don't need to worry about it. Just suffer through it. What's the big deal? Right. And that's what we're working to kind of change, not only that paradigm and that dialogue, but the actual training and teaching of our medical students and our residents and our fellows.
Yeah, I hope that I have a 13 and a 15-year-old daughter. I hope by the time they're experiencing menopause, it's a totally different game for them. And they can thank us all for all the work we've done. So for women in their 40s and 50s who haven't had any signs yet of cardiovascular disease, and they're looking for ways to reduce their risks, what are some suggestions that you have?
Okay, number one, and this probably doesn't apply to most of your listeners, but I'm going to tell you, number one, if you smoke, you must quit smoking. That's the number one thing that you can do for your heart. Number one, quit smoking. Number two, if you are sedentary, you must move. Our bodies are made to be in motion. The way that we live now in modern society is not the way our bodies were built to live. That's part of why we're breaking down, and we've got all this inflammation, we've got all this arthritis, we've got all these issues. We don't really move. And I want to say, and listen, I'm a big supporter of the American Heart Association, a member of the American Heart Association, and we give guidelines on, what is exercise. And, the problem with that is it's easy to say, because we have these guidelines, you have to have 30 minutes of exercise 5 times a week, and it needs to be moderate intensity or high intensity. It's easy to say, but when you step away from it, it's hard to remember. It's like, oh, was that moderate or was that high? Was that 30 minutes 3 times a day, or was it 5, or was it 3 times a week, or was it 5 times a week? If I do one high one week, do I only do 4 days the next? So it starts to be, it's hard to, you just can't remember. It's easy to read and goes, oh, I understand that, but somehow nobody can recall it. And you always have questions. So here's what I just say. As a cardiologist, this is not sanctioned by the American Heart Association, by the way. This is just Dr. Jayne Morgan, a cardiologist in America. Find an activity, a physical activity that you like to do, and do it 20 to 30 minutes a day, 4 or 5 times a week. That's it. Find something you like to do. Don't worry about whether it's high intensity, low intensity, moderate intensity, whether your heart rate's up, whether it's down, whether you need a partner, whether you don't need a partner, whether you swim. None of that. Are you using your arms, using your legs? Does this count as cardio? It's too complicated. And you know what happens when things get complicated? We just freeze and do nothing. So just move your body. Find something you like. If it's walking, just walk. If it's slow walking, slow. Get out there and slow. Whatever your activity is, if it's gardening, get out and garden and crawl around on your knees and get up and get down and get up and get down and move the shovel and climb around and, make sure you're turning it into exercise. Go back and forth to get your rocks and get your boulders and get your mulch and get your stuff and shake it. Whatever your activity is, you do that for 20 to 30 minutes a day. That's it. If you're over 50, try to add a little resistance twice a week. The resistance could be carrying that heavy bag of mulch if you're a gardener.
Yeah. And
putting it on the ground and then lifting it up and taking it to the other location, putting it down. Add some resistance. If you're walking, it may be just adding a weighted vest or something on your arms or on your legs just twice a week. I'm a big Pilates enthusiast. I often teach with bands and with the magic circle just to add a little resistance for my students who are over the age of 50, but even Pilates uses your body as resistance. We really don't even need to add that. This is just mat floor Pilates. I'm not talking about being on the reformer or being on the tower and using the ropes, using the pulleys. I'm just saying, be on your mat. You get great resistance with Pilates, no equipment at all, just the foundational principles of learning how to use your body as resistance. And then on top of that, with my mat students, I often will add bands and magic circles. But again, This is for people who are doing Pilates. Don't do Pilates if that's not your thing. And then you never come to class. And then you don't get the exercise, right? I'm just telling you what I do. That's what I do. Pick something that you like and then do that. The point is just to move. I know the American Heart Association has told you exactly the right thing, and that is the optimal thing. But the fact of the matter is most people can't remember it. Most people aren't doing it. So then we end up doing nothing, which is like the opposite of the intention. So let's come away from nothing and maybe even come away from the AHA, American Heart Association. Let's meet in the middle and let's just get your bodies in motion. Let's just make it really simple and make certain that we can do that.
Yeah, I agree. Guidelines are great, but when you overcomplicate things for people, they just don't do it. And something is better than nothing.
They just aren't complicated, but it's just hard to remember. Yeah. It's like, oh, was that month? Or was it how? Was it 4 days? Was it 5 days? Was it, so it's so specific that when you're reading it, you think, oh, that makes sense. I can do that. And then you step away from it 2 days later, you really can't recall the detail. That's too much. So that just goes to show you that, unless you're a cardiologist, you just aren't going to remember that. And then you get discouraged and you don't do it. Right. Yeah.
And life gets in the way.
Life gets in the way. It's so easy to have other excuses. And I don't want to say life is an excuse, but it's so easy to have other priorities that just move things out of the way because you're so busy trying to sometimes care for other people and get other things done, but also get your job done. And, and then winter comes and it's dark earlier. You like to garden. You want to walk outside. You like to bicycle. That means you got to be out by 4 so you can be back by 5:30. And then it's dark. You're not getting home till 6. And all of a sudden, the activity you picked. Dr. Morgan said, pick an activity. Well, I can't do it because it's dark at 5:30 and I can't go outside. So all of those things definitely get in the way.
Yeah. So you talked about earlier that women, the first heart attack that women have can be fatal because they ignore the signs. So what are some early warning signs of heart disease that women might overlook that we need to be looking out for?
Yeah. And, and I want to be clear, women can have, crushing chest pain and chest pressure and chest burning and left arm pain and diaphoresis, meaning you start to sweat. You become short of breath. But more commonly, because we have smaller arteries and because we develop atherosclerosis oftentimes in a different way, meaning men oftentimes develop it where where they can have sort of, large blockages that suddenly occlude an artery. That's what gives you those sudden symptoms, right? Your part of your heart is suddenly deprived from oxygen or over a shorter period of time than a woman. As opposed to a woman, our vessels are smaller. And we can sometimes just get studding of little patches of plaques along the artery. Nothing big enough to actually occlude, but it means that as the blood goes through, it just kind of has to meander through all the little things. And so over time, you're getting less and less oxygen, but not enough to really block it. And so what happens as you're getting less and less oxygen? You're feeling tired. I feel fatigued. Like, who? Tired? Everybody's tired. Yeah. And then you say, maybe I should lay down. I do a lot. Or maybe you just feel run down. Who doesn't feel run down? Maybe you just have back pain. Back pain is nebulous. And back pain, it could be anything. You might have pain in your jaw, which might send you to the dentist to check out a tooth. You might, and your dentist is not thinking, oh, a 45-year-old woman here who has jaw pain and her oral exam with her teeth now is normal. Should I refer her to a cardiologist? No. You know why? Because the dentists aren't trained. And the dental office is a great place to pick up female patients who are there for pain in their jaw and their exam turns out to be normal. Yeah. That is a great opportunity for the dentist to say, what's the next step on my differential? I need to talk with her about setting up an appointment with a cardiologist. When I tell you we haven't even been able to train doctors, we can't even think about the dentist. We're trying to get to the doctor. But that's a great missed opportunity. And so all of these symptoms, back pain, you're lifting kids, you're lifting groceries, you're moving around, you're getting older. If you have a little back pain, you don't necessarily think, we don't think that I'm having a heart attack. No, you sit down. You might take some Tylenol. You might take some aspirin. You might put a heating pad on your back. Or you might not do any of it. You might just keep going and push through like most women. And so what happens, though, during all that time, your heart is being deprived of oxygen and you're slowly developing a heart attack. And it's one of the reasons why when women finally present to an emergency room or a medical facility, oftentimes we already see signs of a heart attack that's already happened. It's one of the reasons why the first heart attack of a woman is more often fatal than that of a man. And not only have you delayed your care because you don't recognize your symptoms. I'm not blaming women. I'm saying we're not taught them. When I say we, I'm talking about the world, men and women. Like your husband's not going to even say, hey, I bet you're having a heart attack because I read this article with all these symptoms. Like nobody's taught them. Yeah. So literally nobody knows. So it's not just you like, oh my God, I'm blaming myself. Nobody knows. Then when you, and here's the thing, in physicians and cardiologists, we actually are taught them. But we're taught them under the moniker of atypical. We are taught that these are atypical symptoms. And think about how that word drives action or drives inaction, drives thought. That means this is not common, probably not a heart attack. We should keep it in the differential, but maybe she's just a little bit more hysterical or something. But every now and then it turns out to be something, but not typical. That's a terrible word to use to describe that constellation of symptoms that more often happen in women. And so not only do we delay our care, we get to the medical establishment, there might be delay in recognizing it there as well. And now you've got two delays. So you go to the medical establishment and they're sort of doing the proverbial there, patting you on the back. Everything's fine. Doesn't seem like heart disease. You might be having a panic attack. You might be depressed. Maybe you're too stressed with your work, with your job, with your husband, with your family. Maybe you need to take a vacation. You're getting the there treatment when you know you don't feel well, but you're getting the there. That's what I call it. Why? Because that word atypical drives thought, and it certainly drives the thought more so in men there than in women. And we have to remember that the whole medical establishment is filled with people, human beings, who come from somewhere. We all come from neighborhoods, from families, from religions, from cultures. We bring all of our biases with us. No matter how much we work to be objective in our training, inherently, you can still have unconscious bias. And oftentimes we will see that, especially in males treating female patients. And it's one of the reasons why the outcomes of female patients when they're seen by female doctors are much better than female patients when they're seen by male doctors. That is part of that inherent bias, not trying to be a bad doctor, not trying to deliver a bad service, but this is bias of what they think, and you get that proverbial there treatment. And so that's what happens. And every 30 minutes of a delay that you have to get to the cath lab or get that artery open increases your risk of death, of not surviving that event. So we've got so many things stacked against us. That's why we do these podcasts, to empower women, get the information, recognize your symptoms, because don't fault yourself for not recognizing them. You're not taught them. Don't fault yourself for not being taught them. Doctors minimize them because that's how we are taught them. And we don't pass this along to the public. So if you're feeling tired, if you're at midlife, and I'm saying 35 to 65, you're just feeling tired, and we can be tired. I want to be clear. Every time you're tired, you don't have to go to the emergency room. You can be tired. But if you can't shake it, you're just always worn down. You just don't have the energy. Maybe that's it, lack of energy over time. You're just fatigued, or you've just kind of got the flu-like symptoms. You just can't shake them. This flu just won't go away. Those are all symptoms of probably not the flu, probably not just, normal fatigue from, whatever, being up for 20 hours, 3 days in a row. something like that. So you just have your antennas up and to get care sooner rather than later. And when you get there, if you can, have somebody with you who can advocate for you. It's hard when you're the patient to speak up for yourself, especially if you're uncomfortable. Even for me, and I'm a physician in the system, it's hard for me to speak up for myself. And I think that has to do with culture and gender as well. Trying to be respectful of people, even when you're dying.
Yes.
Right?
You don't want to be a bother.
To not insult anyone, even when you're dying. Yeah. Not feeling comfortable speaking up, or maybe you don't want to look as if you're challenging the doctor. It's hard. And I have to do it. And literally, I have all these thoughts in my head and I have to make myself do it. So I've learned to do it. What I haven't been able to overcome is the thoughts, the culture that's in my head of respecting the doctor, respecting the culture, not saying anything, blah, blah, blah. I have the thoughts and I literally have to work against my thoughts and do it anyway. And then thoughts roll me back and then I have to roll my to the thing and then thoughts roll me back. Like I'm fighting it. So I've learned to do it, but what I haven't learned is to control or change what is a natural part of my upbringing. That's what I'm saying, that we all bring our inherent biases and things, to every situation, no matter how much we try not to. I'm a much better advocate for other people, standing up for other people, than I am for myself.
Well, thank you very much for your time today, Dr. Morgan.
Yes.
I hope that women not only learned a little bit about what to look for and how to take care of themselves, but I don't know about anybody listening. I'm ready to advocate for women's health.
Yes,
sign
please.
me up. I'm ready to be on the steps of the Capitol fighting because we deserve better.
We do deserve better. We deserve better. And we've got an uphill battle. We've got headwinds facing us. So, it is an opportunity for all of us to galvanize and sort of push this boulder uphill together. I cannot do it by myself. All the other doctors can't do it by themselves. People have to really want it. And we've got to push for it, push for funding and education and training and change. And that is a heavy boulder with a lot of headwinds. So thank you guys for tuning in today and listening. You guys are part of the change. And I do want to say, if you guys want to follow me, you can follow me on Instagram at Dr. Jayne Morgan, DrJayne I'm on Instagram, but I'm also on LinkedIn and X and Threads and TikTok for as long as it's here. And
if it's still here, yeah.
But, mostly people find me on Instagram, but I am on these Instagram and LinkedIn, but I am on all of these other places. I talk science all the time. I don't always talk women's health. I do talk a lot about minority things, but I also talk a lot about heart disease and exercise. And so it's a place to come to get really good, solid, factual information just on living your healthiest life.
Thank you so much. And thank you for your time today.
Thanks.
Thank you for tuning in to this episode of Women Mastering Midlife. If this episode resonated with you, share it with a friend who might need to hear it. And remember, small changes can make a big difference. We will be back next week for another episode of Women Mastering Midlife. Until then, find us on Instagram at Women Mastering Midlife or my Instagram account, Miss Victoria Byrd, and join us in the Women Mastering Midlife community to share and continue our discussions. We'd love to hear from you. Please rate and review the podcast to help us reach more women mastering midlife just like you. You'll find links to what you've learned here today, as well as ways to connect with us in the show notes below.